After completing this presentation, the learner will be able to understand effective preparation and initiation for the subjective exam, demonstrate effective subjective exam skills, including empathy, asking, listening, road mapping, and signposting, and identify effective ordering of the subjective exam, including key elements such as body chart and symptom mapping, symptom behavior and spins, and patient history. Before your session, make sure to prepare yourself by clearing your mind, taking a breath, reflecting on any emotions that you're currently going through, as well as removing any biases you might currently have. Sometimes at the front desk or a former PT might tell you before your eval, oh, I heard your patient's a big jerk, have fun with that, or they're super lazy. Try to remove yourself from any preconceived notions to provide the best care for your patient. Prepare your setting, make sure that you've reviewed their chart, the table and room is clean and tidy, and your equipment is ready, as well as effective, good nonverbal communication. It's important that we're neatly dressed, have good self-hygiene, have your name tag out. Sometimes people forget your name, so it's nice to always have that available. Posture towards the patient at their eye level and not being lost in your computer. We know that also just having a friendly expression or smiling can reinforce that expectation of benefit for your patient. We're going to go through a few key elements to starting your session effectively, including having a good opening statement, going through patient response, confirming the reason for their visit, showing basic empathy skills, and road mapping, which will help set the agenda and expectations for the visit. Having an effective opening statement can help establish clarity, transparency, and trust with your new patient. You might start with, hello, my name is Dr. Kyle Denlinger. I'm a physical therapist here at CU Sportsmed. How can I help you today? Additionally, you might ask, have you been here before or have you had physical therapy before? If not, it's going to be important to welcome them and set the expectations for the visit, how long the appointment's going to last for, what you hope to achieve, what you hope to look at. There are four main reasons that patients usually seek consultation: symptom relief, diagnostic clarification, reassurance, and legitimization of their symptoms. Sometimes you might hear, oh, I can't do X, I have a hard time with Y. That's going to be more of that symptom relief category. That's what we see a lot. Sometimes you might hear with diagnostic clarification, they start with a history of their condition. Sometimes it can be short. They just want you to help them figure out what's going on. Sometimes people are overwhelmed. They want some reassurance that things are going to be okay. They might have a story that may or may not be relevant to what you think is relevant. And sometimes people just need to unload and vent, and they want legitimization of their symptoms, knowing that it's valid, the anger or frustration they're going through. And they might start with a long, rambling history that dates a while back. So we're going to be going through basic subjective exam skills, including empathy, asking skills, listening skills to facilitate responses, and not interrupting as well. Dr. Aaron Taylor will also be going through further helping skills and motivational interviewing. As we initiate the session, showing proper empathy can really help to understand the client's world from the patient's internal frame of reference and communicates this experience to the client. It's cognitive rather than emotional, an understanding of experiences, concerns, and perspectives of the patient, and it's an ability to communicate this understanding. Many empathetic sentences involve validating what the patient is feeling. So if we're verbalizing it, sometimes you might hear sentences like, I'm sorry for what you've gone through. That sounds really tough. I can see how hard it must have been to you. Or that sounds really difficult to have gone through. This conveys full understanding, relatedness, addresses their reason for the visit and their response, and also allows the ability for them to correct you. Summarization and repeat back skills are also crucial in showing proper empathy to your patient. For example, so what I'm hearing is that we need to figure out what's going on so you can feel better. Or, am I understanding you that you don't know what's happening, you can't reach down to pick up your child, and we need to figure out what's happening so we can help you? Or, I'm hearing you sprained your ankle and we need to get you back to tennis. All of these examples demonstrate that the PT is actively listening and truly hearing what the patient is saying. As I mentioned previously, setting proper expectations with your patient is crucial for having an effective visit. Road mapping can be a very effective way to do this. For example, here's what we're going to do over the next 45 minutes, overviewing your visit. In the subjective, you might say, I would like to ask you more questions that will help me figure out what we need to examine so that I can help you. Before the objective, the examination will look at strength, range of motion, flexibility, etc. I'll talk you through what I'm doing so we are both up to speed. And then as you get into treatment, after that, you and I will have enough information to help put our heads together and create a game plan together. This provides the patient a sense of control, empowerment, relatedness, and connectedness. Another way to provide structure in your subjective exam is signposting. Signposting summarizes what you did or what you know and kind of provides a thinking out loud, shares what's next with treatment or examination, and asks permission to proceed as well. It empowers the patient for providing them more control. Transitional statements can also be helpful with this. So a signposting example might be, first, you're summarizing. So you have symptoms of numbness and tingling down your arm. This might mean your nervous system is involved. Then you might share, we're going to do a neuro exam to help us figure out what's going on so we develop a treatment plan. And then 3 is getting permission. How does that sound to you? Having effective asking skills also is an empathetic technique to use in your subjective that gives the patient control. You want to ask permission to ask. So, for example, do you mind if I ask about your health history instead of, I see you marked hypertension and depression on your intake form? This also provides full disclosure on why you might need certain information. For example, sharing your medical history helps me determine the best way I can care for your health. In your subjective exam, impact questions can be considered the heart of the exam that really goes into their goals, how their issues impact their life, and they're often open ended. For example, how is your pain and weakness affecting your life? Tell me what you're going through with this condition. Or one of my favorites, if somebody has chronic persistent pain for many years, what would you do if you didn't have this pain? That kind of really gives them the opportunity to tell you their true goals and ways that you can help them best. In the subjective exam, there are 3 basic components that we need to be aware of: area of symptoms, symptom behavior, and patient history. Expert clinicians that perform at high levels are able to keep all of these separate. Many exams can have a varied order based on how the patient can guide the interview. However, these are the 3 main paths of question that can be performed. The question is, if a great clinician keeps symptom behavior and patient history separate, which one should you do first? Here is a list of some key information to obtain in your subjective exam. It includes chief complaint, patient history, medical treatment and medications, location and quality of symptoms, behavior of symptoms, general history, social history, psychological history. What we don't want people to start with is their barstool story. This is the story you get when you start the visit with, tell me what happened. This can really open a can of worms in many cases, where the person might start with, oh, back in 1995, I was golfing, I took a swing, I felt a pop, I went to the doctor, got an image, said I had a bulging disc, had prednisone, went to the chiropractor. Sometimes it worked, sometimes they popped me, they put me on stim, I tried some traction, blah, blah, blah. It makes you lose a lot of time. Sometimes it can take 20, 30 minutes. This is the same story that they tell everybody who asks them about their pain. Even though they've told this story so many times, it's well evidenced by the fact that this person's no better despite telling this story a bunch. We need to get symptom behavior first. And I might recommend shuffling your exam in this way. We don't want to get barstool stories because it can be a huge waste of time. So once again, it can be hard to order it this way, but we'll go through some strategies in a little bit to help organize this. Sometimes if a patient has an acute onset or is in severe pain, that sometimes the history can probably come first. If the disorder is chronic or persistent, getting the behavior might be very crucial to get earlier. If there's referral down the leg or the arm, We definitely need to decide whether this is radicular or not, need to define the clear area of symptoms before going into either the history or the behavior. So if we reshuffle our order like this, location and quality of symptoms, that includes getting your body chart of the patient. This might be what we start with to create our clinical patterns in our mind. This can help us even start building hypotheses before getting into the patient history and symptom behavior. This is crucial for having a more effective subjective exam. Then we get into either behavior or history, and those can come at different times. There's not necessarily a preferred order. The patient can guide that a little bit too. And then all of that distills down to a final initial hypothesis list going into your objective exam. Before establishing history, we need to know exactly where the symptoms are to effectively help create clinical patterns for recognition. Then going into your subjective, we can tailor questions to the top hypothesis generated from the patterns noted. This helps to further refine your hypotheses as you continue moving towards confirming or refuting in your objective testing. We need to establish relationship. Is P1 related to P2, or can they happen independently? Is S1 tingling related to P1 or P2? This can further connect issues and guide towards a common hypothesis. So for example, you might say, John, can you stand up and show me where the pain is in standing? You might say, John, where's your shoulder bothering you? You got their hands on your shoulder, you're tracking the pain up and down and below. Uh, you might point to that posterior shoulder pain. You're right alongside of them. You're mapping out their symptoms. Does it spread? Does it go to the elbow? Do you have any numbness, tingling? Anywhere they say no, you're mentally checking off or checking it off on your body chart. And to clarify, you are filling in this body chart. This is not what the patient has filled in. You're asking what the quality of pain is. What is the nature of the pain? They might not volunteer things like neck symptoms right away. So, like I just had a patient recently. They say, "Oh, I've always had a stiff neck or a bad neck, but I'm just here for my shoulder." We still need to know that because if a patient comes in with any complaint in the upper extremity, we need to know about central issues as well. Your exam would end around T8. We would screen verbally anterior and posterior to every region above T8. If you have a patient with left lateral knee pain, for example, every area of the body screened anterior and posterior up to T8. Why T8? With clinical pattern recognition, issues above T8 tend to refer to the upper quarter, such as T4 syndrome, T4 through 6 syndrome. You get that bilateral glove paresthesia. On the other hand, main syndrome or TL junction dysfunction, that's T10, 12. Symptoms don't tend to go up or go down. They tend to go down and out. So TL junction would not refer up, it would only refer down. So that's where you get bilateral glute, groin, testicular pain. T8 is a great cutoff. Some things below tend to not go up, and things above tend to not go down. Now, you always still do your check marks because you have to accept that sometimes there's exceptions. For example, cervical myelopathy. You're screening balance, and you could always do like the cervical myelopathy cluster, but in the majority of cases, T8 will hold true. After we map out these symptoms, then we go into AGS and EASes. We're using their language specific to their what they've provided to us. So specific to that right sharp shoulder pain, what makes this better or worse? We get irritability as well. We will look at relationships. When in the arm do you get when do you have the arm symptoms? Do you get neck pain, or do they come on together? Or is it possible to get it without the neck pain? You need a check mark. You can't walk away from symptom behavior gathering until you have a check mark or symptom behavior everywhere. If not, you can't honestly say you have cleared a region verbally. This is where you form your initial hypothesis list. This will bring you from a good to a great clinician. So considering the subjective presentation pattern, what could be going on with my patient? What could explain this pattern? What are the symptom generators? These are some of the things that we might be asking you in mentoring and that you should almost be reflecting yourself with every patient that you see. You know, you might have some times where the physician script says rotator cuff strain, evaluate and treat. It could be, And we need to have that on our differential, but we need to be sure. The treatments can be totally different if it's coming from somewhere else, for example. An infraspinatus trigger point could mimic radiculopathy. Posterior glute min can mimic L5S1 radiculopathy. Could be rotator cuff strain. Could be two mechanical different shoulder pains. We need to consider different presentations. If it's bilateral in nature, if it's numbness and tingling down one arm, we might need to rule out the lumbar spine, lower cervical. If we have nociplastic pain where it's spreading, we need to treat that differently too. If it's shoulder, neck-related shoulder pain, that could be peripheral neurogenic. All of these different presentations require different questions. So as we talked about with the body chart, when you're looking at location and quality of symptoms, we need to consider the structures in the region of pain, if it's local nociceptive especially, what joints are in that area, what muscles, bones, ligaments, nerves, viscera. That's how I want you to think. We also need to ask about joints above and below the chief complaint. We know with regional interdependence, this is appropriate to ask about. We additionally need to ask about remote structures that could refer into that area or somatic referred issues, such as facet referral that's local at the neck, but it can refer down a little bit, down towards the arm. Patients may not be as ready to offer this information about the low back with knee pain or neck stiffness with elbow and hand pain. Many don't even realize it could be related. It's our job to figure that out. It's also important to figure out quality. Quality can help us distinguish potentially what tissues are involved. Burning, numbness, tingling in the posterior lateral knee is more likely to be neural compared to a sharp or aching pain, which could be more local, joint, or ligamentous. All of this data that you collect will help to create those clinical patterns and initial hypotheses that we will test with clinical pattern recognition and eventually hypothetico deductive reasoning. One of the most effective things you can do to improve your therapeutic relationship with your patient is, before moving on from your body chart, recap to the patient what you found. It shows that you were paying attention and that you care. It explains the clear clinical picture that you have of their current situation. Sometimes you'll hear from this, wow, nobody has ever listened to me that well. They will think you have a comprehensive understanding of their problem. It was detailed, and you spent time to make them feel heard, that someone finally actually listened to them. Now, what do you do if a patient refuses symptom mapping first? Most people are going to understand. If a patient tries to interrupt you constantly with history, you might say, hey, could you hold that thought for 1 second? If I can get all these symptoms on board and then dive into where, when, and why these things are happening, I will be able to have a better idea what's going on and be able to do a better job. No one is going to refuse having a better clinical picture of what's going on. Nobody wants you to half-ass it. You might say, hey, do you mind if we hold that thought for 1 minute? I need this info to make more sense out of your story. If you make it about them, usually people will always be understanding. Patients deep down want to be heard well. So for example, we go back to John. Hey, John, what happened? All we know is that they have posterior shoulder pain. They tell you a 10-minute story. It gives us no relevant info. It does not allow you to understand them better, what the symptom generator is, or what the best way to solve the problem is. What you could say is, hey, can you show me where it's bothering? We map out the symptoms. Then we can figure out, okay, is it local nociceptive shoulder? Is it peripheral neurogenic cervical C5 radic? Is it nociplastic? We form an initial hypothesis list. And then you can say, hey, thanks for all that info. Now, can you tell me what happened when your neck and shoulder pain came on? The difference is, now that you know that John has all of these symptoms, you can ask appropriate follow-up questions that you never would have known to ask. So when John says, hey, when I got that injection, now you can ask where and not assume the shoulder. What treatment to the neck helped the shoulder? This might help shuffle your hypothesis list. This makes the history matter. You can never ask any of these questions unless you did a symptom mapping first or a body chart first. You can't shuffle hypotheses or differential diagnosis in real time unless you order it this way in the majority of your cases. The real kicker is if you're the first person, you're going to end up doing it this way, but you're going to need to go back and redo the whole history, and you have no idea what the clinical pattern is you're looking for. That's the mistake that you can make if you end up doing the history first. This order is more efficient, and I believe it is one quality that can make you an expert clinician. There is a small percentage of patients who genuinely need to be heard, and you just need to let them unload their story first because they're bubbling over with emotion or anxiety. They have issues at home, yellow flags, they're crying, they're angry. For those situations, sit down, open up your body language, and let them suck your soul for 45 minutes. It's your therapeutic duty. They need it, they're fed up with the system. You're not going to get a good symptom behavior or body chart in these patients. Maybe 5% of patients might fall in this category, maybe more if you're seeing clientele that are more persistent pain or complex. But in those initial cases, you're going to be looking at identifying stressors and work on decompressing with these patients. So, more key information to obtain in the patient history is behavior of symptoms. That includes aggravating factors, easing factors, 24-hour pattern, sleep habits, and SINs, or I'm adding in SPINs, which adds pain phenotype. We'll go into that more next. Aggravating factors can provide insight if a condition seems mechanical or not. It's better when I stand, it's worse when I sit, it's only with these types of movements, that sort of thing. Easing factors can provide you into the patient's locus of control. If they only use hot packs or massage or passive things, they might have a passive locus of control. Or if they talk about exercise or walking, maybe they have more of an active locus of control. If they have a 24-hour pattern, you want to go through how's the morning, how's throughout the day, end of the day, after work. Do you have night pain or sleeping pain? How's the workday versus the weekends? Stuff like that can help us figure out what's going on as well. And then finally, going into sleep hygiene, which we know is more and more important as physical therapists to assess. How many hours of sleep do they get? How many times do they awaken from the pain? Sleeping positions, do they feel well rested or drowsy? We know that pain is very important to be aware of for persistent pain and developing persistent pain, as well as proper recovery. SINs were initially pioneered by Jeff Maitland, but the International Spine and Pain Institute introduced the concept of SPINs in adaptation to Maitland's SINs, with the P adding pain generator or pain phenotype. Pain identification is far more complex than simply differentiating pain versus tissue, and most often is the likely result of both. In the next section, we're going to go into what is involved with the SPINs.